Today we will be talking about how to access and de-access a Portacath. My name is Fiona O'Riordan. I'm the Specialist Educator for Paediatric Neuro and Spines at Nottingham Children's Hospital.
And I'm Dani Jones. I am the Regional Educator for the East Midlands for children and young people with cancer. Our objectives today, we will discuss what a Portacath is, including indications and contraindications, advantages and disadvantages of having a Portacath, the location of a Portacath, the different types of ports and the different types of needles, and any complications. We will also cover what equipment is needed, and there will be practical demonstrations of both accessing and de-accessing a Portacath. So what is a port? It is a totally implantable central venous access device. It is usually inserted surgically under a general anaesthetic by a paediatric surgeon or interventional radiologist. And the port is a small plastic or titanium chamber with a self-sealing silicone septum which the needle is inserted into.
Indications for having a port, so children who've got poor vascular access and have complicated conditions, so children with long-term epilepsy that might need rescue medication, haemophiliacs that again might need rescue medication, neonatal graduates that have obviously had their veins ruined when they were little and have ongoing complications. Children with long-term conditions like cystic fibrosis that we know are going to need constant IV antibiotics for their treatment, and contraindications. So there aren't that many contraindications. We wouldn't advocate putting a Portacath in a child that's needle phobic for obvious reasons, and you might consider not accessing the port if we think the child might be septic and you don't want to give them a septic shower.
So the advantages and disadvantages of having a port. So the advantages, they aren't visible. Once it's needled, you can see it externally, but otherwise you can't see the Portacath. The children and young people are able to go swimming. They can have showers and baths much easier with a Portacath once it's not needled. And if it isn't needled as well, there are no attachments to worry about that can be pulled or tugged on or removed accidentally. And also it only needs to be flushed every 4 to 6 weeks, which makes it easier for the child and family. They don't need to come into hospital as often. They don't need as many community nurse visits. And then the disadvantages, again, there aren't many disadvantages. However, it does need to be needled each time. So in a needle phobic child, that isn't the best idea. And there is still a risk of infection with a Portacath.
The Portacath is inserted under the skin, usually on the chest, and tunneled centrally into the internal jugular vein or superior vena cava. Sometimes it can be a little bit lower down, depending on the development of the child. The most common type of Portacath used in children is a single lumen port. However, you can get double lumen ports and a power port, but these are less common. And a Huber needle is a specialised needle with a non-coring tip with a side-facing bevel that must be used when accessing a Portacath because it prevents damage to the silicon and extends the life of the Portacath. There are lots of different types of needles that you can get, and a few of these on the screen are examples of those.
So when accessing a Portacath, so when we are needling it, depending on the trust you work in, this would either be done as an ANTT process or done as a sterile procedure. Once needled, the needle can be left in for 7 days unless a risk assessment for that individual patient states otherwise. Only using Huber needles and following your local trust policy. If it is done as a sterile procedure, this is usually done as a 2-person technique, and once it is needled, if you have followed a sterile procedure, once it is needled, you just follow an ANTT process to access as with any other central line. But something important to remember with a Portacath is when we are locking it, we would use 100 units in a ml heparin solution and 4 mils of this, unless, again, contraindicated for that individual patient.
So to prepare your equipment, the things that you are going to need is the correct size Portacath needle, and this is generally dependent on how far in the Portacath is, and they usually come in half an inch, 3/4 of an inch, or 1.5 inch needles. Chloroprep to clean, a needle-free device, 3 times Luoloc syringes, unless you're going to be taking blood or giving antibiotics or other medication, then you would need extra syringes for that. 2 times chlorhexidine alcohol wipes, just in case you need to clean the bung after you've needled it. 1 blunt fill needle to draw up your saline, 1 filter needle to draw up your heparin. Dressing, ensuring that it is a breathable, clear dressing so that you can observe the site after it's been needled. A 1 times 10 ml ampule of sodium chloride, 2 2 ml ampules of 100 units per ml of heparinized saline. If you're doing ANTT, then non-sterile gloves, and if you're doing it sterile, a pair of sterile gloves. And also for sterile, you'll need a sterile field for your tray and one for your patient as well.
So now we have our tray all set up, we're going to attach the needle-free access device and prime the needle to get rid of any air. Now for your patient, you need to make sure your patient is in a comfortable position for them, and always make sure their back is supported in case they try and lean back away from you when accessing their device. If you're doing this as a sterile procedure, make sure that you put your sterile field underneath your patient before you start. So first we are going to clean the port. So using our Chloroprep, we're going to go in a up and down and side to side motion to make sure we are covering the whole area. And we're going to do this for 30 seconds. And then we're going to allow that to dry for 30 seconds before we access the port. So to access the port, we're going to take off the protective sheath, making sure you're holding on to the top of the needle as well as the side so you've got a good grip. And then you're going to locate your port with your other hand, so with a C shape, either top or bottom or side to side, just to locate and secure the port before you put the needle in, and then right in the centre, just push the needle straight in, and it should feel nice and firm and in place. We're going to make sure we take our 2 ml discard to make sure it's in the right place. Then we are going to flush with a push-pause technique. And then lock with our heparinized saline. Always clamping under positive pressure. Then you're going to put a dressing over the top to ensure it's secure. That's it. Done.
What complications do we need to look at when accessing the Portacath with the needle? So the first thing you would be looking for, to ensure it's in the correct place, you would want it to be bleeding back. So when we talk about it bleeding back, we aren't referring to a flash back. We are talking about a good volume of about 2 mils of pure blood to know that it is in the correct location. Other complications when accessing it, so it could be painful to the patient. You can also get pinch-off syndrome, which is where the line internally is stuck underneath the collarbone, and it could be causing a kink. And also another complication to look out for when you are accessing it is port flip, and this is where the Portacath itself has completely flipped over. So rather than when you're feeling the bouncy silicone in the middle, you would just feel the hard, flat base of the back of the Portacath.
So to de-access the port, you need to make sure that it has been flushed and locked with heparin before we take it out. Remove the dressing. Ensure that you support the port so that you're not pulling out on it, and pull the needle out. You may want to put a spot plaster on .
So what happens on the day when you come to join us? Everyone will have a practice of accessing a Portacath on a dummy chest. So we will talk through the steps as a quick reminder. You will have a go of inserting the needle safely. You will flush the needle and you will then remove the needle. We would like everyone to be competent in accessing their Portacaths, so please send any assessments or bring any assessments with you that you need to be signed off with.
We have provided some references and additional resources for further pre-course learning. Thank you for listening. We hope you have found this pre-course material beneficial, and we look forward to seeing you at the Difficult Vascular Access in Children course.